going to start to respect everybody's time. Just a quick reminder that we are going to be recording this session. And also the Spanish one from later on, we will be posting that on our YouTube page, and we will also put an announcement out on our Facebook page that will take to the link on YouTube. So if any of you would like a link to the recording, afterwards, we will be posting a survey where you can add your email to it, and we will let you know when we have any other symposiums, as well as share the link with you, and anything else that the center as well as Parkland share with us, we are able to go ahead and share that with you all with their permission. So again, thank you so much for joining us. My name is Iris Contreras. I am the Mental Health and Community Outreach Coordinator at AVANCE. It is my pleasure to be here with you guys and share on this topic, which we've all heard of depression at some point and anxiety out in the community. And we've heard maybe from organizations or TV or friends or community partners on what depression looks like and symptoms. But we still have to dive in a little bit deeper into seeing how it specifically affects men and women, because we do show those red flags, but in different ways sometimes, and that is completely okay. What matters is that we all have an understanding of it and that we know how to assist somebody when they need to be referred or when they need to be heard. So again, thank you so much for joining us to hear about this wonderful topic. Today we have with us our friends from the Center for Integrative Counseling and Psychology. We have Veronica and Joy, and I will give them a minute to introduce themselves in a little bit. And from Portland, we have Mr. Andrea Moran. So thank you guys so much for joining us. And we have Montserrat Mata, whom is the parent educator / caseworker for our Well Together initiative with Texas Health Resources. So I will open up the floor to Monse to introduce herself, share with you guys a little bit of how today is going to look, and then we will go ahead and do introductions with Veronica, Joy, and Mr. Andrew, and we will begin with the presentations, which will start with the center.
Thank you, Iris. Appreciate it. I'm sorry, I'm a little bit sick, but I want to try to talk a little bit louder. But thank you so much, everyone, to join us today in the symposium. I really appreciate it, and hopefully, you can enjoy this topic about depression. And by the end of the presentation, we can have any questions for the audience. So Veronica, Joy, or Mr. Moran, they can answer any questions that you have about this presentation. And like Iris mentioned, by the end, also I can share the PowerPoint and the link about the symposium. And we have the time for Veronica and Joy to introduce themselves. Thank you.
So I'm Veronica Guerrero, and I am one of the mental health professionals helping with the presentation today. My license is licensed psychological associate. So I can and do provide therapy and also help with psychological evaluations to provide diagnoses and treatment recommendations at the center. And a little bit about myself, Mexican-American, bilingual, and yeah, that's pretty much it. I'll let Joy introduce herself.
Good morning. I'm Joy Delser. I'm a licensed professional counselor associate. And it's been a delight to work with AVANCE over this last year so that I've been working at the center. Veronica and I have received several referrals from AVANCE, and just really appreciate being able to work in the community. So thank you for giving us all this opportunity. A little bit about myself. I worked as a nurse for 9 years and then decided that counseling was the way to go. So I'm a bilingual counselor as well. And Veronica and I worked closely with clients in West Dallas, South Dallas, and other areas of Dallas. So, okay, I'm going to go ahead and pull up the PowerPoint presentation, and Veronica's going to start us off.
Okay. Yeah, and we have time to do the introduction for Mr. Moran.
Awesome.
You're muted.
Okay, there we go. My name is Andrea Moran. I'm a mental health counselor, licensed professional counselor, supervisor here at Parkland Hospital. And right here, I mostly work with the homeless population here in Dallas County and with the shelters that provide services for them. And I think that's it for now.
Thank you.
Thank you so much, everybody. The floor is all yours, Joy and Veronica.
Awesome. I'll wait for, let's see if technology doesn't fail us and we can get the slides up. And if not, we'll just roll with the punches and I'll pull it up on my end and just talk from there. So we'll see here.
Okay, perfect.
But yeah, just while Joy gets the slides up, I just want to share that the portion that we're going to share, I'm going to start off our presentation and then Joy will do the second half. And oh, it looks like it might work. Hey. And I'll kind of dive into defining depression, domestic violence, and then Joy will take the part of talking about the gender differences of domestic violence and depression. And I might comment a little bit on the depressive symptom presentation differences between genders. So we'll dive right in. What is clinical depression? I have found in my personal circles of friends and family, and maybe some of you guys have experienced this as well, where the word depressed or depression gets thrown around a lot. And so, you know, you might hear of, oh, I'm depressed, or, oh, you know, I'm feeling really down. And a lot of times, sometimes people are actually depressed, but other times people use the word depression to describe sadness. And so sadness is a global emotion that everybody experiences. Sadness, just as, you know, maybe anxiety or other emotions that we all experience if we've lived long enough, probably longer than a year, we've experienced sadness at some point. But what, from a psychological perspective, we consider to be clinical depression that requires intervention. I'm going to describe some of those symptoms here. And so typically, a diagnosis may be given if there are some of these symptoms for at least 2 weeks or longer. So depressed mood, which most of every day, almost every day, it's kind of chronic. Sometimes we might feel sadness, but we get cheered up or we get distracted. And 2 days later, we're feeling better, we're bounced back and we're back to normal. That's sadness. Depression is a little bit different. It tends to linger. It kind of, you can try to, you know, snap out of it. It's not working. You know, you're just feeling that way for most of the day or almost every day for at least like 2 weeks. Like that's kind of the mark that was determined we would classify as like, okay, this is, you know, after the 2 week mark, we're going to look into this and we might need some intervention. Also, people have a way diminished interest or pleasure in activities most of the time. So if you normally enjoy volleyball, sports, or watching movies, if you're experiencing a depressive episode, you're going to find that you're not enjoying them to the same level you used to, or you might not even enjoy them at all. And so the things that you would normally enjoy, you're finding you're not really getting that pleasure or that same enjoyment that your normal self would. Whereas sadness, you know, you might get cheered up by those things. With depression, there are changes in appetite. Some people lose their appetite, forget to eat, or don't want to eat. Some people cope by overeating, and it's, you know, chronic. We find that that's not just a one day or a one meal thing. This is like a ongoing thing. Same with sleep. Some people experience insomnia. They are losing sleep. They're unable to fall asleep. Or some people oversleep. They're sleeping not just 8 hours, they're sleeping 10, 12 hours or more, maybe because of avoiding those intense emotions or not having a motivation to do things. Some other symptoms include, we wrote here, this is fancy terminology, psychomotor agitation retardation, basically moving. So like some people, when they're experiencing depression, they feel the need to just constantly move. It can be almost like a type of anxiety. I need to move, I need to do things. Or some people, it's the opposite. They feel sluggish. They don't really move, or they move really slowly, and it's noticeable to those around them. Along with this, fatigue or loss of motivation. Some people have low self-esteem, feelings of worthlessness. So, feeling like this sense of unrealistic guilt, that I failed myself or my family or other people, or I don't deserve to live. That goes into the last point there. So just a low self-esteem. And also with depression, there's concentration difficulties. So it's not as easy for people to maintain attention or to concentrate on their daily tasks, or even just a conversation. Sometimes they might find they're in a conversation and their mind just goes blank and they're like, I just totally missed that. And it's not because of ADHD or anything else. It's just because of the depression. And the way we can differentiate that is, did you have concentration difficulties before being depressed? And if you didn't, that might be an indicator. And the last point there is suicidal ideation, meaning just thinking about death more often. It might not even be to the point where there is a plan or a desire to attempt, but just a desire of like, I don't even want to live. I'm tired. I'm emotionally exhausted. I don't want to be here anymore. That's already considered suicidal ideation, even if it's passive, even if it's not an active, like I'm going to complete this on this day. Both, could be found in a case or a person that is experiencing a depressive episode. And I just want to comment before continuing on to domestic violence. I just want to comment, there are differences, and Joy might speak to this, between males and females, women and men, when it comes to the presentation of depression. And part of the reason for that is the literature has shown that there's a difference in coping and in approaches to issues from men and women. So women tend to usually share and cope by talking with others, or sometimes women may have the tendency to overthink things or to really think through things, whereas men have a more of hands-on practical approach to situations that's solution oriented. So women have been more prone to experience depressive episodes, but men are more likely to complete suicide. And there's different reasons for this. So women may attempt suicide, they don't always complete it, but men, there are higher rates of suicide success. And usually it's because it's through more violent means that have a higher success rate, like firearms or just more violent means. And so that's something that research has shown. And so depression might look a little different, there might be more rumination and different coping for women, and for men, there might be, more substance abuse or more other things to try to compensate for the depression. And once they're already contemplating suicide, that's a higher risk depending on personality and whether or not there's a plan that they may follow through with. I don't know if there's any comments you want to comment on that, Joy, before I dive into domestic violence. If not, you can definitely share it during your slides.
Sounds good.
Okay. So we'll go ahead and jump into the next one. I know that was a lot of information. So if you guys have any questions, please feel free to make a mental note or write it down. If you're, sitting somewhere, write it down, because we don't want you to not ask. But definitely keep those questions in mind so we can address them. So domestic violence. I took this quote, and we have our resources listed at the end of this presentation. So I took this from a domestic violence website. So it's also referred to as intimate partner violence, dating abuse, relationship abuse, but generally it's a pattern of behaviors used by one partner to maintain power and control over another partner in an intimate relationship. So what it boils down to is power and control. And in this next slide, I'm going to talk a little bit more, and Joy, you can switch the slide, about some statistics, and then defining more what that domestic violence may look like. So some stats, just to give an idea: 1 in 3 women and 1 in 4 men in the United States have experienced some form of physical violence by an intimate partner. So that's 1 in 3 women, 1 in 4 men in the US. Next point, around 40% of Texan women, or women in Texas, and 34% of Texas men experience intimate partner physical violence, intimate partner rape, and or intimate partner stalking in their lifetimes. That's almost, I mean, it's not too close to the 50% mark, but for women, it's 40%, which is pretty significant. And the last statistic I included, in 2019, 150 women in Texas were killed by a male intimate partner. 1 woman was killed by a same-sex partner, 31 men killed by a female intimate partner, and 3 men were killed by a same-sex partner. That was in 2019, which is sobering and saddening to read that has taken place. So we're going to go a little bit more into domestic violence. Joy, if you don't mind switching the slide. And there we go, the power and control wheel. So when we think of domestic violence, I can think of a couple of clients where they were told by their partner or spouse that domestic violence is only physical. And that might be something that we find in Hispanic communities or in other cultural communities, ethnic groups, where in their home countries, when it becomes physical, that's when intervention is made. But here in the United States, we acknowledge the psychological and emotional components that often keep people trapped in those situations, and those warrant intervention. So this wheel, I may not read everything here, I'm just going to summarize, kind of depicts what that is. So in the black outer circle, we have physical violence, sexual violence. Those are the external things that we can easily see and often have like physical evidence for. But the white parts that are surrounding the power and control title show other things that are taking place emotionally, or kind of, it's not tangible, but it's happening. So that includes intimidation, emotional abuse, isolation from family and friends, minimizing, denying, and blaming. So a lot of times gaslighting happens where a person is basically being told that their emotional reality is not valid. And a lot of times victims of domestic violence start to question their own emotions, start to question their own reality, and start to think that they're crazy at some point, because what they're experiencing is not being validated by anybody else, because they're isolated. And the only voice they're hearing is that of their intimate partner that is abusing them. And so there's gaslighting or being unvalidated is very common. Some cases, children are used to coerce or to threaten. If you leave me, you're going to lose custody over the kids. If you take the kids with you, I'm going to go after you. I'm going to chase you down. We're going to have a legal dispute. There's a lot of threats that take place. Some even use pets as a similar form of threatening. Economic abuse. So keeping, tabs on the finances, or even withholding access to finances. That means maybe taking away debit cards, credit cards, checkbooks, if some people still use those, as a means to control and maintain the power in the relationship and in the circumstances. And in here is included male privilege, which isn't always the case, because we acknowledge that there are same-sex relationships, or sometimes it's the woman who is the perpetrator. But we have found that male privilege tends to be something that takes place when the man is the perpetrator. So sometimes that includes making the woman be kind of a servant, or in the Hispanic community, machismo is something that kind of fuels the domestic violence in the relationship. And so at the center here, we have the power and control. All of these things have in common, including the physical violence and the sexual violence, the desire for power and control. And that's kind of at the core of what domestic violence is. So again, if you have questions on any of this or comments, please make mental notes and write them down so that we can talk about this in more detail. This next slide goes over the domestic violence cycle. And there's different things you could find on Google, how the cycle looks like, but they all follow the same pattern. Tension is building, there might be some arguments, some disagreements, some offenses, And then there's some sort of explosion, you know, that might include physical violence, that might include sexual violence, or some kind of outward expression of, you know, that usually instills fear in the victim. And then after that, oftentimes there's what we call a honeymoon period, where the perpetrator, the person who explodes, will either remain calm for a long time, nothing really happens, there's no incidents for several days, weeks, sometimes even months, or a year, where there's just no incident, everything seems fine. And then again, tension is building, and explosion. And sometimes during that honeymoon period, there's apologizing. Oh my gosh, I lost control. If you just hadn't done that, I wouldn't have lost control. Why can't you understand me more? If you had just done this and this differently, I wouldn't have gotten so angry. You know, I'm so sorry, forgive me. And there might be like roses, or buying chocolates, or finding ways to compensate. But sure enough, tension builds again eventually, and there's another explosion. There's more bruises in the victim. There's more violence that takes place. And usually what keeps victims in that cycle is the belief that the perpetrator, their partner, is going to change, or just lack of finances, lack of the means to get out of the situation. The third one would be fear of leaving. Sometimes they're afraid that they might lose their life in the process of leaving, which unfortunately has happened at times in certain cases. Those are the three. And at the end of our presentation, we do have a list of safety housing in the Dallas Fort Worth area. And there are social workers at these places that help work with victims to create safety plans to escape these situations when their life is at risk. And even if your life is not at risk, finding ways to leave that situation, to save your life, and even, you know, and to be in a place with your children where you can become independent and outside of these situations, financially, emotionally, psychologically, and practically speaking. We can go to the next slide, Joy. And you can take it away. We'll let Joy take it away.
Okay, so Veronica and I are talking about the relationship between depression and domestic violence, and also gender differences. So that's a lot of different factors that play in, because there are depression symptoms, and then there's the domestic violence, or intimate partner violence concerns. And then on top of that, there's gender differences. And so what I'm going to cover is just kind of a really, really broad view of some things that were coming up for me in the literature that talk about the connection between men and women and experiences of depression and the relationship with that and domestic violence. So to just kind of give a very broad overview. But I think the core of kind of the question we're asking is, if there is someone that is experiencing domestic violence, what are some of the signs and symptoms? And we're aware that depression is often one of the signs and symptoms that someone is experiencing intimate partner violence. And then how is that expressed differently across genders in general trends? Interestingly enough, there is not a whole lot of research on depression in men as connected to domestic violence. Less so anyway than research for women. And seeing the numbers, there are more women that experience intimate partner violence than men. And so it does make sense that there would be somewhat less research. But I decided to start with a representation of men who are victims and depression in men, because it felt to me like there's a lot of emphasis on women, but the literature itself is saying we need more research on men. So I thought, well, let's at least represent that at the beginning and say, let's talk about that first. So we're going to kind of go through the similarities between the genders, talk a little bit about women, but then kind of go through a long list of how depression is often exhibited for men, and just kind of those differences. So some things that are true for both genders are that a family history does increase the risk of depression. and that stress can trigger depression in both genders. So that's a similarity. And then some of the differences then are that for women, a lot of times the outward expression of depression tends to be expressed in things like changes in sleep patterns and eating patterns and anxiety. In fact, a lot of times there is a connection between increased anxiety and depression in women particularly. And that is a difference between women and men. And then also just talking about how hormones do play a role, especially for women, in how they experience depression, and how that is another difference between genders. But here is a long list of depression symptoms that men tend to exhibit. And for sure, women can experience these too, but men tend to externalize their depression symptoms in a different way. So women may talk about their depression, they may seek more social support, whereas men may exhibit it outwardly in examples like more aggressive behavior, escapist behavior, being more controlling, abusive or violent behavior. Which is very interesting, because if a man is experiencing depression, he may be more aggressive and more abusive. So he may be a perpetrator of domestic violence. And I think so often we talk about how kind of the victim of domestic violence may be the one who's experiencing depression. But it's also very interesting that the perpetrator, the one who is expressing the abusive behaviors, it can actually be a sign that they're depressed too. And so there is a relationship between those two, which is very interesting. So y'all can kind of look through the long list. I'm not going to read every single one of these, but once again, noting, as Veronica was saying, that suicidality in men, completing suicide is more often something that we find statistically happens for men than for women, whereas women make more attempts at suicide. They tend to not be completed suicide. So it's like overdosing on medication and things like that, but they tend to not be lethal means, whereas men tend to use firearms or other more violent means. And so there are higher rates of suicide in men than in women. And then are less likely to seek social support, and less likely to talk about depression, and less likely to seek professional help for depression. So just kind of going to talk about the relationship between domestic violence and, I apologize, it should be intimate partner violence for IVP. But younger women and women with low social support are at greater risk for depression, and also tend to have less access to be able to reach out for help if they are experiencing domestic violence. And for women experiencing IVP, studies suggest that there is a cultural difference that is present in the presentation of depression symptoms. So we now have widened the net even farther. It's not just gender differences, but also we're looking at cultural factors too. So there's just a need to look at all the different factors that play into how depression looks across genders and the cultural differences, and across just different kind of all of those different barriers play a piece in being able to identify depression, and then whether or not there's domestic violence that is occurring as well. And then there's some research that talks about bidirectional violence. So bidirectional violence is when you have one partner who is initiating the domestic abuse, and then the other partner responds in the same way by also being abusive. And so there's also just a commentary that it's not always where there's one perpetrator and one victim. Sometimes both partners are perpetrators of the the abuse and the cycle continues. And that tends to be a lot more complex than one partner. So there's a lot at play. And then also talking about how women may present with depression and anxiety symptoms. But what's interesting is often women will present with those symptoms, but they're not being asked if they experience intimate partner violence. And so a lot of times there's the symptoms there that something might not be right and might not be going well at home, but the questions aren't being asked. And so kind of the suggestion is that because of that, there's a real need to be able to screen more often for intimate partner violence and to be able to ask those questions, because we might be missing a lot more both men and women who are experiencing some kind of domestic violence at home. And then there's also a big difference in how both men and women define intimate partner violence. So women are more likely to include things like when Veronica was talking about the power cycle and power and control. A lot of times women will also describe things like kind of the psychological control or emotional abuse or verbal abuse as a part of domestic violence, and men are less likely to include that. They will often report domestic violence as physical aggression. They don't talk as much about the emotional kind of aggression that may happen, which is very interesting. And then women experience the effects of intimate partner violence much longer than men do. And it's very interesting because women may have a lot longer road to recovery. For example, if they are married and they leave the marriage, they may experience what we term as femicide, which is basically rejection from their social network, or kind of like almost being punished for having made the move to leave, whereas men are less likely to experience those kinds of effects when they leave an abusive relationship. And so there are even like social aspects, and those are very much interconnected with social aspects of what it's like to leave an abusive relationship. And so there's research that this may also affect depression levels, because if a woman is experiencing all of the stress of having left an abusive relationship, she may have to deal with the outcomes of that for much longer than a man will, which will also affect depression levels and will likely kind of perpetuate those depression symptoms for longer. Interestingly enough, women report that they feel relief of anxiety and depression when they share with others and when they disclose that they have been experiencing domestic violence. And so that's really a pull to encourage sharing of those kinds of experiences, because even in sharing and tapping into social support, there is a lot of relief of symptoms. So even if they are staying within an abusive relationship, if they're talking about what's going on with someone else and receiving social support, their anxiety and depression tends to be a lot lower because they talked about it. So just to encourage that as well. Okay. And then Veronica was just including some of these different shelters and just some resources here in Dallas. I just want to say that speaking of the clients that we're seeing, a lot of times that is true, that a lot of the social factors are very significant. The cultural social factors are significant for women as they're even considering identifying that they are going through abuse, and then also what that looks like to get help. So taking those steps is very challenging and does affect their mental health well-being. It's very distressing to consider leaving a partner, and does include a lot of anxiety and depression symptoms. Okay. Is there anything else you'd like to add, Veronica?
No, not. The only thing I guess I wanted to emphasize, or I guess ask Monse or whoever, if sending out the DFW safety housing to, or just providing that, just in case anybody that's listening, or even on the Facebook page, if somebody knows of someone that would benefit from that resource, I think that would be good to have access to.
Yes, absolutely. Thank you guys so much. That is wonderful information and education, because that's one of the reasons why we wanted to talk about the difference between men and women, just because of our difference in outwardly demonstrating, and then other things that it might affect, like intimate partner violence. As Joy mentioned, sometimes we don't take into account that the reason why a gentleman might be more aggressive or more physically aggressive towards somebody might be because there is an underlying mental health issue. So that's very important to take into consideration, and we will be sharing those lists of information that Veronica and Joy shared, as well as anything else that we are able to find in the literature. And Mr. Moran, the floor is yours.
Good. Well, I think Veronica and Joy covered a lot of the material, and so I will try to speak to maybe some of the reasons behind. I think women are more likely to take their children, for example, for medical care, are more likely to seek help than men, and so. That would be that would explain some of the factors regarding why women tend to maybe get more treatment for it than men. Some of the, as I said, also men tend to blame circumstances and others for maybe their depression or their circumstances in life, where women tend to blame more themselves for what's happening. Sometimes men tend to create conflict versus women try to be nice. There's a lot of differences in the genders, and a lot of those are affected by cultural things, cultural backgrounds, those kind of things. As I said, men tend to be more lethal. About 80% of, compared to women, of the 80% of the suicides are male in the United States. And then it also fluctuates. Maybe in midlife is when mostly men, although after 65 years of age, men are 7 times more likely to commit suicide and to be lethal with that suicide. A lot of other factors might be with women, puberty, postpartum depression. Those are some factors that affect women, and that a lot of times they do get addressed if they are getting the adequate medical care that they need, right? But they're more susceptible to that because of that. But I think, gaining access to the depression, obviously when you go to your medical provider, it's, they don't necessarily, they'll ask, maybe here at Parkland, we do a screening question that really asks people basically just 2 questions. Are you feeling hopeless? And it has to do with their energy level too. And then after that, depending on how they respond to those questions, we'll ask more questions regarding sleep, appetite, and those things. But it's important too to to think about, how it's experienced on a personal level, and how we, am I likely to speak up? Do I have that permission? Do I give myself permission to speak up and seek help? And for men, a lot of times they'll seek help, but further down when it really gets severe. Women are more likely, they're more verbal, they're more likely, I don't know the veracity of this study, but it says that women use about 5,000 words a day compared to 2,000 of men. I don't know how they measured that, but that's just, an indication maybe that women are more likely to express, to seek help than men. So that would explain some of the differences too in recording of depression. A lot of the differences, I think, too, between men and women might be women get a lot of accolades. Men with where men were doers. And so a lot of what is, we're used to completing tasks. We're generally not good listeners. Women are expected to be better listeners. And so there's a lot of those differences that really contribute to whether we're going to get help. A male is going to get help or a female is going to get help. For men who maybe with depression, they might sleep too little. A lot of it has to do, they might continue working, thinking, I have to still perform and do that. Where a woman will be maybe more likely to sleep more. Women will tend to develop also co-occurring disorders, which might be an eating disorder. Men are more likely maybe to develop substance abuse problems. Okay. So those are some of the, sometimes those get blurred too, because maybe I found that a lot of times the substance use will get addressed. And so a person will go into substance use treatment. And then after that's treated, the depression will kind of emerge because they've been self-medicating through substances. So there's a lot of different ways that men camouflage, so to speak, or that it's not through work and those kind of things, where women may maybe tend to self-medicate through other means. Trying to think if there's anything else that I could say that would help. I think that, like I said, a lot of times it's important to consider, as Joy and Veronica were saying, it's like, okay, what is it with irritability, anger? A lot of times that really kind of gets the attention, but really not the depression. I do several anger management groups, and a lot of times what's the underlying, it's like the iceberg, right? So it's under the anger is really just a lot of depression that hasn't been treated.
Absolutely. Thank you so much, Mr. Andrew. And another one of the things that we've noticed with specifically the participants at AVANCE that are either in our parenting classes or in our case management classes is that one of the things that also helps women identify those symptoms of depression within themselves, even if sometimes they don't know about them, is their children. their children will say, Mom, you've been sleeping a lot, or Mom, you haven't been wanting to go out to the park with me lately, or Mom, you're eating more than you're used to. You're crying and I don't see the reason why you're crying. Is something wrong? So that alerts women into also seeing the changes in their behaviors, whereas in men, their behavior changes are sometimes not seen because, as you mentioned, our society has placed men in a place where they have to be task oriented, and so their focus is in bringing in that income into the household. So they might feel some of the physical symptoms of depression, but they attribute it to them doing physical labor. Oh, my head hurts, but it's because I've been out in the sun. Or I feel tension in my shoulders, but it's because I've been carrying around the blocks or doing cement mixing and stuff like that. Or I've been mowing the lawn. So the men tend to pay more attention to those physical things rather than emotional triggers. And if there's an emotional trigger, they'll just say, I'll just go drink a beer with my buddies or go fishing and I'll be good in a week. And it just stays there, and it becomes a cycle of managing the symptoms but not truly addressing or identifying. So it is interesting how even our children and the tasks that we perform in our household have an impact in the way that we address depression within ourselves or within our families. And with that, I open up the room to our attendees to see if you all have any questions or anything else that you may want to ask or share with Joy, Veronica, and Mr. Andrew, as well as you all. If there's anything else that you all may want to share, Veronica, Joy, Mr. Andrew, please feel free to do so. So the floor is open for discussion.
Hi, this is Aurolina Valdez. May I ask a question to the participants?
Yes, absolutely.
And thank you so much for the information that you shared with us. I was wondering if it is possible to refer clients to you, Spanish-speaking clients. I am also a therapist. I work at Lumen Education and Backman Lake together in the North Dallas area, but I'm frequently finding that, of course, I need to refer elsewhere. Is there a way to refer to you guys?
For me, they have to kind of be fit a certain criteria. They have to be kind of homeless, and not they have to be kind of homeless. They have to be homeless. So that's a criteria that's pretty set.
And how do they reach you? I mean, if we do have people in that circumstance, how?
So if they would contact Parkland Hospital, and if they would contact within Parkland Hospital, what we call the HOMES program, HOMES program, yes.
Okay.
And we would either right now, currently, because of the pandemic, we can either do that over the phone, visit with them, or they can come in person here, and we can do that too. But we have a couple of clinics, physical clinics, where we could meet in person, or we can do it over the phone. Yeah.
Okay.
And let me tell you what, Aurolina, can I give you my direct number?
That'd be great. Thank you.
Okay. 214 590
590
3055.
3055. Thank you so much.
You're welcome.
And I will be putting Mr. Andrews' information in the chat so
Awesome.
that anybody that wishes to have that on hand can have that.
Okay, thank you.
Yeah, and also I want to add with that, Mrs. Valdez, I can share my information just in case if you need more information about mental health. AVANCE, we have this program, the Well Together program, where we can educate, families and the community about mental health. and also
Okay.
includes the mom, the dad, and also the kiddos. If they need any referral for counseling, we are partnered with the center, so we can do the
Okay.
referral for them too.
Okay, excellent. Yes, I'm aware of Avance's services. We
Okay.
are sort of partners with you guys, and you do
Yeah, under the
fantastic job. So I'm glad to know that then the center is your alliance for mental health.
Yes. So I'm gonna
Okay,
share my email address and phone number just in case if you need it.
thank you.
and I've
And I
also
apologize that my camera is not on. There's a million things happening here, but thank you.
Oh, no, it's okay. It's okay.
You're okay, no worries, no worries. For the resources that Joy and Veronica had on the shelters and Mr. Andrews' information and the homes program, I added the survey that I mentioned earlier in the introduction to the chat. If you guys fill that out, it has an area for an email address. If you add your email address on there, we will send out all of that information to you guys.
Thank you.
And through Avance, also Monse will send referrals to my supervisor and myself, and we kind of screen to see if a client can be approved through Well Together. But we do provide bilingual counseling up to 20 sessions for ages 10 through 39. And I'm currently seeing clients on site in Mission Oak Cliff, so in the Oak Cliff area. But there are some different kind of qualifiers that include age ranges and zip codes. And so that's where we start screening. But yeah, we are also working in some other locations and can do virtual counseling too, depending on if someone meets the qualifiers for counseling.
And if I understand, if I remember correctly, you guys do have a sliding scale, right?
We actually, through Well Together and Texas Health Resources, the counseling services are free of charge if they meet the qualifiers. And so it's free counseling. And then if they have some kind of insurance, we can also see about a referral to one of the clinicians that accepts insurance as well. But yeah, anyone that's working in Well Together and Texas Health Resources, they can get the free counseling up to 20 sessions. So
and
wonderful.
I want to add to that as well. If they do qualify for those grant funded services, and if they're needing a psychological evaluation, that's what I'm starting to do this year. My job role is changing. So if you have somebody, Aurolina, who would benefit from having testing for whether it's a mood disorder or trauma, or cognitive stuff, so neurodevelopmental disorders, anything like that, if they may qualify for a free evaluation. My license is licensed psychological associate, but I'm being supervised by a licensed psychologist. So that would be signed off by both me and a licensed psychologist, free of charge. So that's, if they qualify, that's a great opportunity. And otherwise, our main office at the center, they also provide, if they don't qualify for the grant funded, they may be able to do a sliding scale fee with either myself or a doctoral level intern under the supervision of a psychologist.
Okay, thank you so much, everyone.
Thank you. And I put a question on the chat, and it is, what can I do if I'm worried about my mental health? If I'm a woman or a man?
What can I do? I would say if it's if just seeking out maybe a therapist to check in. I think one of the cool things that we've seen in recent years is that the stigma around mental health is, I believe, is slowly going down. People are going to therapy not just because of an intense issue, but even just for smaller things. So I would say if it's within the finances, or if you qualify for, a grant funded free therapy, just checking in with the mental health professional. You can only gain from that, I believe. But feel free to chime in, Joy or Mr. Almora.
So I think a lot of it is like in the Hispanic community, a lot of it is speaking to the deacon of the church, or a lot of the faith communities with an elder, with a pastor, with a minister, with a rabbi. A lot of it is, speaking with your primary care provider, and, sometimes screens work, and sometimes folks ask these questions, but sometimes they don't. So a lot of the times it's about, being proactive and asking for help. I think, I know here at Parkland, because suicide is one of the 10 top, we're in the business of keeping people alive. That's one of the things we do, is we do a depression screen. And I know when I go to see my private physician, he does the same thing, because that's something that needs to be addressed, that historically hasn't been addressed.
It seems like maybe one of the secondary benefits of the pandemic is that it seems like it's kind of triggering past trauma. So clients that, it seems like a lot of clients I'm seeing in the Hispanic community are experiencing a big increase in depression and anxiety. And so I think they are more worried about their mental health, and more likely to get help because of the isolation. And so I just think that it'd be interesting to kind of reflect on, have I ever felt like this before? Not just in the last couple years, but have there been past times in my life where I felt like this before? And sometimes there seems to be a connection between trauma, between kind of being enclosed in spaces, between grief and loss, and it's triggering just even the nature of the pandemic. Even if you haven't lost a close loved one, if there hasn't been grief, being isolated or having to stay in quarantine is triggering in and of itself, because it brings up very similar feelings to a traumatic event in the past. And so I do think that it kind of has created an environment where mental health is less of a stigma and more of just being a little more normalized of, I really need help, something's not okay, and my family is close to me now, they're not at school as much, or we're sick more often. And so I think some of the symptoms are sometimes intolerable. And so I think the encouragement of what can I do if I'm worried about my mental health is to understand that that you're not alone, that I'm not alone, that all of us are experiencing at some level some form of stress and anxiety. And there can be a lot of unity in just sharing about it and talking about it with each other, whoever that is.
Absolutely. Thank you so much. I think that, as you all are mentioning, the first step would be to share with somebody that you trust, and then receive support in outreaching to a community service agency or to a therapist. And another one of the things that I think that with our program families we experience is not knowing how to tell somebody that they are concerned about their mental health. And I think honestly that as family members, it's even more difficult, because you don't want to pressure somebody or make them feel like they are doing something wrong. And even ourselves, one of the interesting things about our English sessions is that the majority of us are providers. We either provide education or a different service in the community. And when families come to us and say, how do I tell my husband that I think that he needs therapy? Or how do I tell my wife that the symptoms that she has been experiencing are of depression without making her feel more depressed? And sometimes even ourselves as providers don't know how to navigate that. Are there any suggestions that the three of you may have?
I thought of a story. So I have, without like providing detail, obviously keeping it vague, I have a client who was experiencing domestic violence. And in her isolation, and also just not being educated on how things are run in the United States, she felt very hopeless. She felt that if she were to leave the situation, she was going to lose her kid. She just didn't She wasn't aware. But when she decided to speak up and reach out to somebody, it changed everything for her, because the person she spoke out to ended up, connecting her with the center, and then I ended up seeing her, and then, fast forward months, and now she's aware of the safety housing resources. Now she's aware of, oh, I won't lose custody of my child if I choose to leave. Oh, and now and so in a lot of ways, sometimes somebody is afraid to either speak up for themselves, or the contrary, somebody tell the person in need of help that they need help. And I think that's the moment where it's very scary. It's scary for the person speaking up because they don't know what's going to happen. And it's scary for the person speaking into that person's life in this different scenario, because we don't know how they're going to react. But what can happen after that can change, and we know this as providers, can literally change their life story, or change, the narrative that they're living. And so I would say that it might vary from situation to situation how to communicate that, or how to speak out for oneself, obviously depending on the specific factors. But I would say more times than not, it is definitely beneficial, and the pros would outweigh the cons. And I mean, just a story I thought of, she went from, thinking about death, not wanting to live, feeling helpless, to now feeling motivated, and she got a job. Now she has hope. She knows that she can become independent if she had to. It's a whole two different scenarios. And the difference was she decided to speak out and reach out for help.
And since you mentioned their fear of their losing their children, or their children being taken away, I guess that could be a difference between how men and women experience depression. I've never heard a man worried about losing his children. Not that he doesn't care, but there is not that societal threat on them. I mean, if they acknowledge that they have depression, there might be a better understanding of them. I've seen a lot of women who are afraid of saying I have depression, because the system is going to take my kids away. They are going to take my kids away. So I wonder if that is I know that that's keeping a lot of female clients from reaching out for help.
Yeah.
Oh, yeah.
And I think maybe even the way that it's presented as well, saying, hey, but if you reach out for help and receive help, you'll become way more competent in your ability to be able to be present with your children, versus,
Sure.
it getting worse, and then their fear possibly, coming true. We wouldn't say that always happens, but.
Mm-hmm.
Mm-hmm.
Okay, thank you. And I have a question: how depression can be diagnosed and treated?
I would say there's different ways for it to be diagnosed. So I think more commonly people end up just seeking out, if it's diagnosed, right, seeking out therapy. And in the process, the clinician would recognize the symptoms and determine if they're meeting the criteria for the official diagnosis. And I think that the purpose and, identifying, sometimes people are afraid of using a label because, like, oh, we don't want to box somebody in. But for some people, it's a relief. They're like, oh, I'm not crazy. I am depressed. And it's a relief to know that that's what they're experiencing, because now that the problem is identified, we know that there are effective ways to treat depression that help people. And so it almost provides hope, which is a huge deal in cases of depression. One of the markers of depression is hopelessness. Mm-hmm. And so once that's identified, usually, to answer the question, I would say it's in therapy. Not everybody seeks out a psychological formal evaluation, because those tend to normally be pricey. Not everyone looks for that, but I think more often times it's through therapy. And the cool thing is that they're already jumped into therapy, which is normally the treatment for depression. So they get it identified, and then once it's identified, moving forward with what can help them.
Okay, thank you. Do you want to add something, Iris?
I was just going to say that there's different modalities that are used in therapy. So one of the biggest things that I preach to our families is advocating for yourself within the therapy room. You can ask what different type of modalities there are, which one has been more successful with different cases to see which one fits you. And I know that there's some places where if you start with one modality, that's what you stick with. And then there are other instances where if you start with one modality and it doesn't work, it's not providing the outputs that we want, then we use a different modality, and that's okay. So also speaking to your therapist and your provider and advocating for yourself, but as therapists or as psychologists, truly we can't know if you are truly being perceptive to the information until we do evaluations to see how things are going in the therapy room. So truly you speaking for yourself and your family members, if they are also in therapy, them speaking for themselves within the therapy room and advocating, that's what's going to lead to better results within a therapy setting, within a therapeutic setting.
Okay, thank you. There's something else they want to add, Veronica, Joy, Mr. Moran?
Any other questions that you all may have, Ms. Esmeralda, Ms. Jody, Ms. Arlena?
I'm fine, thanks.
Okay, perfect. Then thank you all so much for your time. We will give you back your rest of your day. Thank you so much for joining us. We hope that you all truly enjoyed today's information and that you go out there and make an impact in your communities with what you've learned, and continue doing the service that you're doing within your organizations. And we will within our organizations, because as we know, it's truly creating a positive impact. So thank you all so much. And thank you, Veronica, Joy, Mr. Andrew. We will see you guys in our Spanish presentation if you all are joining us then at 1.
Thank you.
Thank you.
Goodbye.
Thank you.
Bye-bye.
Have a good one.
You too. Thank you.